Thank you for tuning into my channel. Today I'm going to be talking about newborn screens, or what I like to call your baby's first tests. To tell you a little bit more about myself and my qualifications for leading today's presentation, my name is Rosana Lastra and I'm a board certified pediatrician. I'm also the founder of Head2Toe Pediatrics, a concierge practice in the Tampa Bay area, offering house calls to families for well and sick visits. As a pediatrician, I also round at the hospital and see babies when they're first born to do their first checkup. From my personal experience, I can tell you that parents put a lot of thought into the birthing experience and how the pregnancy is going and what the first outfit for the baby will be and what names they're going to pick. But a lot of times I encounter that parents may not be fully aware of what baby's first tests are going to be, or they may not understand why these tests are offered and recommended for their baby. To start off, we're going to talk about the blood test, the newborn screen, also known as the PKU. So the blood test PKU is done within the first 24 to 48 hours of baby's life. And this time frame is very important because a lot of the conditions that are tested on the test depend on babies having been fed. And if baby has not been fed, it can alter the results of the test, where you may get a false negative, which means that the baby may have this condition, but the test comes back negative. The earliest this test can be done is within 12 hours of baby's life, but most routinely it is done before the baby is discharged from the hospital if the baby is born at the hospital. For babies that are born at a birthing center or at home, the midwives will do this test when the baby comes back for their follow-up appointment, or when the midwife goes to visit the baby at the home for their follow-up appointment, which is usually around 48 hours of life. The goal of the heel prick test is to identify, diagnose, and manage conditions that are treatable. And that is the main key takeaway, is that these conditions are treatable. So if there is early identification and treatment can be started early, it can prevent permanent developmental damage, mental retardation, and life-threatening illnesses. And there are three main categories where all of the conditions that are tested are put into, in addition to some other conditions that don't fall into this category that are also tested for. In Florida, the newborn screen tests for over 55 conditions, and I like to classify these as conditions within the endocrine department, the metabolic department, and the genetic department. I do want to delve a little bit deeper into three different conditions that are identified by the newborn screen to give you a better idea as to why we test for these conditions and how it can impact the baby's lives, especially as they get older. So I'll start with the endocrine category. And for endocrine disorders, what happens is that the body is either making too much or too little hormone. And I will talk about congenital hypothyroidism, and that is a condition in which the issue is that the babies are not making enough thyroid hormone. And the thyroid hormone is very important for metabolism and for growth and development. So if baby is not making enough of this hormone, they will have issues with their growth and their development as they get older. Some signs and symptoms when it is congenital hypothyroidism, initially the babies will be asymptomatic. And congenital hypothyroidism doesn't happen in babies whose moms have a history of thyroid disorders. So that's very important to distinguish. So usually congenital means that the condition is present since birth, which is what this newborn screen is testing for. And these babies, either their thyroid gland didn't fully develop during the fetal process, or the thyroid gland did develop, but it just is not functioning as it should be. So, completely unrelated to maternal history of thyroid disorders. Now, the treatment for these babies is to replace the thyroid hormone. So it would involve giving thyroid hormone in the form of medication daily. And these babies would be followed by a pediatric endocrinologist, which is a doctor that specializes in hormones for kids. So it would be very important for them to continue the management with them. Now, if it is left untreated, or let's say the newborn screen was not done and we do not know about whether this baby may have this condition or not, 5 to 10% will develop symptoms, but it's not until later on in life, usually around 3 to 4 weeks of age. Some of those symptoms can be very non-specific, and it could be related to other conditions as well. But on the slide, you'll see some of the symptoms that you may find when someone presents with congenital hypothyroidism. Now, if it's untreated, what we worry about is that it may result in mental retardation, developmental delay, and growth retardation. If it's detected early and treatment is given, those things are much less likely to happen. And these babies could lead completely normal, healthy lives. Now, with all of these conditions, I will also talk a little bit about the frequency, because it's important to also understand how frequent these conditions happen or how common they may be. So for congenital hypothyroidism in the United States, 1 out of every 3 to 4,000 babies are born with congenital hypothyroidism. And we could go on and on about these conditions, but we're only going to give a quick snippet of each. So we're going to move on to metabolic. With metabolic conditions, what's important to understand is that babies with these conditions, there are enzymes that are either missing or not working as they should. And we are going to talk today about MCAD, which stands for medium chain acyl-CoA dehydrogenase deficiency. And the issue with this condition, which is also identified through the newborn screen, is that the babies are not able to convert fat into energy because of the missing enzymes. So when this excessive fat builds up, this can then build up in the liver, in the kidneys, and in the heart. Now, signs and symptoms, as with the congenital hypothyroidism, a lot of babies, especially initially, will be asymptomatic when they're born. Symptoms could develop between 3 months to 2 years of age, but again, I want to emphasize that if we are waiting for symptoms to develop before we identify these conditions and treat them, we are not going to be able to reverse any illnesses, any conditions that arose because of the condition being left untreated. Now, the treatment for MCAD is a special diet and frequent feedings. So you want to avoid fasting, because fasting will make these babies go into what we call a metabolic crisis. And a lot of times for these babies, parents will also be given a sheet with a plan by the geneticist, which is a doctor that specializes in genetic conditions, on what to do should the baby become ill or go to the emergency room, because these babies will require special IV fluids through their IV line if they get ill and end up at the emergency room. So there's lots of stuff related to MCAD in terms of signs and symptoms, or how it can affect the children as they get older. But if it is left untreated, it could result in brain damage, in breathing problems, and even death. It is estimated that about 1% of SIDS cases are actually due to MCAD and are being misdiagnosed as SIDS. When we talk about the frequency, 1 out of every 15,000 babies in the United States is born with MCAD. Moving on to genetics. So genetics, these are inherited conditions, which means that these conditions that we're identifying usually run in the family, or they're due to gene issues, but it's a new mutation in that baby, or what we call a de novo mutation in that baby. We're going to talk about galactosemia today, and the issue with galactosemia is that the babies are unable to properly digest galactose. And galactose, if it's undigested, it builds up in the blood. And this is a sugar molecule, commonly found in dairy products. So signs and symptoms, following the same trend as the prior disorders we've talked about, usually babies will be asymptomatic when they're born. A few days after milk feedings is when you'll start noticing some symptoms. And the reason is because if you are starting with breast milk or regular infant formula, it all contains dairy. And as the infants or the newborn babies are eating this, they're not processing that galactose, so it is building up in the blood and they will develop symptoms. The treatment is to eliminate dietary galactose, and this can be extremely hard, especially for mothers who are wanting to breastfeed, because classic galactosemia is a contraindication to breastfeeding. There are different forms of the deficiency that would still allow mothers to continue to breastfeed, but initially, if it comes back in the newborn screen that there is a concern for galactosemia, babies will be put on a special formula until further testing reveals what type of galactosemia they have. If it's left untreated, it can result in brain damage, it can result in failure to thrive, cataracts, which is a condition that affects the eyes, and death. Frequency in the United States, 1 in every 30 to 60,000 babies is born with galactosemia. I'd like to proceed to show this next slide with some common questions that I may get from parents. And the first one is that there has to be a family history for any of these conditions to come back positive on the newborn screen. So if I am certain about my family history, why would I need to do the newborn screen? And my answer is that babies with identified conditions on the newborn screen generally come from families with no previous history of the condition. So as we talked about earlier with the different categories, some of those can show up with absolutely no family history. Now, there are conditions that are screened for, such as sickle cell disease, where frequently you may see family history of this condition. But even with the genetic conditions, there are some conditions, like I said earlier, that are de novo, which means that it is completely new for that baby, due to a change in the DNA during the time that the fetus was developing. Now, the next question that I can frequently get is, these conditions won't cause my baby to die, so why would I need to do a newborn screen? And that is one of the reasons why I specifically talked about MCAD and galactosemia, because those are conditions that could cause babies to die, especially if they're not identified. And sometimes these conditions, if they're identified and we start treatment, then we are decreasing the likelihood of the baby dying from these conditions. But I do want people to be aware that we do screen for conditions that could cause death in babies. Maybe not right immediately after they're born, but certainly within weeks to a few months after the baby is born. And then the third question, my baby will show some signs and symptoms. And yes, eventually, infants with these conditions will show some symptoms. But when are they going to show those symptoms? Are they going to show those symptoms when they're 2 and they've already been left untreated for their whole first 2 years of their life, which is huge for developmental progression and growth? So I always tell parents, do you feel comfortable knowing that if this is not diagnosed until 2 or 3, are you comfortable with the consequences of what that could mean for your child's growth and your child's development? So that is very important to recognize that. Then the other thing is, yes, when they do show signs and symptoms, are we going to know immediately, oh, that's because it's MCAD, or yes, that's because it's galactosemia? The answer is no. We're going to be doing a lot of different testing to try to figure out what may be going on, but a lot of these conditions could initially present as an infection. Maybe the doctor might put the child on an antibiotic, they get better, but then a few months later they get sick again, and then you're like, why do they keep having infections recurrently, right? So it will also take time to, once the child starts showing symptoms, to come up with the accurate diagnosis when it's due to one of these preventable conditions. So I'll leave you with those tips. And then this next slide here is just to emphasize the importance of the newborn screen. So every year, approximately 225,000 babies are born in Florida, and 700 of those newborns have an identified condition that is detected through the newborn screening. And again, if these conditions are detected early, it can lead to healthy lifestyles if treatment is started early. And then a positive screen, the newborn screen is just a screen. So a positive screen does have to be confirmed with additional testing. So it's important to remember that. And then if it is confirmed through this additional testing, these babies will need to follow up with more than just their pediatrician. And a lot of times this will involve following up with a variety of specialists. And then I'd like to conclude the last few slides that we'll be presenting here with the next 2 newborn baby tests that are done. And the next one is the hearing screen. So the hearing screen, babies will have headphones or little electrodes that are placed on their forehead, depending on the type of test that is being done. And this is also done within 24 to 48 hours of baby's life or before they're discharged from the hospital. If baby is born in a birthing center or at home, they will be given a referral to go to an audiologist or a hearing screener to get this test done before the first month of life. And the goal of the hearing screen is early detection to provide interventions that will improve communication, education, and overall social development. And the two different types of hearing screens that are done are the autoacoustic emission, or OAE, and the second one is the auditory brainstem response. With the OAE, the infant will just have earphones on their ears. With the auditory brainstem response, they will have little electrodes around their forehead in addition to an earphone in their ear, similar to the photo here. And that is because with that one, they're also looking at the brain waves. And then hearing loss is one of the most common birth defects in the United States, with approximately 2 newborns per 1,000 newborns are born with hearing loss. And that's every year. And then the next is the congenital heart screen. And the congenital heart screen uses sensors, such as the one in the photo, to look at pulse oximetry, or oxygen level in the blood. This test is also done within 24 to 48 hours of the baby's life. And for babies born at the hospital, it will be done before the baby leaves the hospital. For babies born at a birthing center or at home, this is a test that sometimes may not be done by the midwife. So it's very important to notify the pediatrician that the baby will be following up with, to let them know that the baby will need to have this test done, as it can be done at the pediatrician's office. And this screen identifies critical congenital heart disease. And what is that? So critical congenital heart disease, there is different forms of congenital heart disease. And congenital heart disease means that there are structural problems in the way that the heart was formed. Now, sometimes some of these structural issues may be identified during a fetal ultrasound, and it may require additional specialized ultrasounds for the baby. So that would be like a fetal echocardiogram, which is an ultrasound specifically looking at the structure of the heart in the fetus. But like I said, that is sometimes and not always. So pulse oximetry is done because it will detect 7 of the critical congenital heart diseases, and there are more than that. So what is the issue? The issue is that there is low blood oxygen levels because there is a problem either with the heart or with the arteries leading to the heart. Initially, most babies, following the trend, will be asymptomatic. They can develop symptoms a few days after they're born, and those symptoms can also be very non-specific. It's important to recognize this because the treatment could involve surgery, and if it is identified while the newborn is at the hospital, a lot of times that will delay their discharge because they will be needing to be monitored at the hospital to make sure that their oxygen level is not dropping too much, or to determine when they may need to have that surgery, if it's going to be sooner rather than later. And if it is left untreated, it can result in failure to thrive, which means that the babies are not growing. It could result in recent infections, it can result in heart failure, and it can even result in death, depending on the structural issue with the heart. The frequency in the United States, there are about 40,000 babies a year that are born with a heart defect. And this is just any heart defect. One out of 4 babies who are born with a heart defect will have a critical congenital heart defect or heart disease. So very important to recognize that early. Given all of the information that we discussed today, I always do like to encourage my families to do all of these tests for their babies. So the newborn screen, the hearing screen, and the congenital heart screen. and I like to provide the families with all of the information that was discussed today, and even more depending on what their questions may be. But if a family chooses to refuse these tests, in particular the newborn screen, the heel prick PKU, or the hearing screen, it is required that that is reported to the state of Florida, and that will be something that the midwife or the hospital will do and submit that report. Parents may also be asked to do a letter where they are declining or to sign paperwork provided by the hospital or the midwife stating their decision to refuse the test. I hope that you found today's presentation useful and that you learned something you may not have known, and that you will use this information to educate and empower your families. If you have any questions about anything that was presented today, or if you would like a copy of the slides that I presented during today's presentation, feel free to email me at drlastra@head2toepediatrics.com. I also do a lot of educational series and provide information for families and anyone who follows me on Instagram. And my social handle is at Head2Toe Pediatrics. So I invite you all to follow me and stay involved.